introduction.
Yes, here you go.
Thank you. Okay. Hello, everyone. Really, really great to be here. I had the pleasure of meeting H2O actually about 2 weeks ago in California, and got to meet a lot of other people that are similar to you guys. I know there's a lot of data scientists in the audience, and some executives and VPs and things like that. So my job today is very easy. I'm just going to share my experience with you in the healthcare setting and try to frame what we're doing in healthcare and how you're absolutely needed for us to be successful. I named this Artificially Intelligent Healthcare, Realigning the US Healthcare System, because I have some great news for you today. I have actually figured out the US healthcare crisis. I have the answer, and I will share some of it today. So just a brief agenda. I'm going to tell you a little bit about me just so you get a feel for where this information is coming from. I'm going to talk about complexity in the healthcare space in multiple levels, from the ivory tower all the way down to the bedside, the challenges that we're facing currently and in the future, and then the solutions, and that's where you guys come in. And we'll summarize and then have a brief 5 to 10 minute Q&A session. So a little bit about me, and I should, as we all should, introduce ourselves. I'm a dad, I'm a husband, I'm a son. This is the most important thing that I do, that I think we all do. And I'm also a chief medical information officer. And another name for that is the chief techie. So I'm the chief techie in my organization. I'm sure that you guys and your friends and family are probably considered chief techies, most of you. And so for me, the way people think of me where I am is the way I think of you guys in this venue. So I'm pretty technical, but I'm nowhere near as technical as most of you, and nowhere near as smart, I can tell you that much as well. I'm also an entrepreneur. I'm involved with a lot of, a number of startup companies and my own businesses, and I have a practice as well. My practice, however, is very, very small now. I'm relegated now to locums work, which is a few days a month. But I do it, even though it's kind of hard for me to do it, I do it because I love taking care of patients, and I really love being at the bedside. And locums actually pays very well, so it kind of makes it a little bit easier. I get to fly around all over the country and see all these great healthcare organizations, from small hospitals to large academic centers, and I steal all their great processes, and we share our own too. I didn't mention the integrative care. So recently I transitioned from conventional practice to what we call integrative practice, which includes conventional practice. And I'll talk about that a little bit later as well. So starting out with complexity. So everybody knows that we in the healthcare space have a lot of complexity. Nuclear power, airline, defense, any type of chemical manufacturing. These are all very complicated spaces, but we like to think that we are the most complicated. And just to talk about that a bit, so we have the reason why we're all here, and the reason why there's so much money involved in US healthcare is, look at our ranking around modern wealthy countries. We are last on this list. And there's many lists, and we are either last or close to last in terms of value. So value is defined by quality over cost, and what this is telling us is that our quality is much lower than our cost, which is much higher compared to other countries. And drilling in this a little bit deeper, because we're all, well, you all are all data scientists, and I'm a wannabe data scientist. This is the top 19 causes of death. I'm not sure why they didn't have 20. It was interesting that they have 19. And notice the third cause there, other. And we typically, when you see these kinds of lists, you'll see that type of word, other. But that word, other, actually includes medical error. And what this is saying, I think this is from 2015. This is the British Medical Journal did this evaluation. That 250,000 people had death from us, our fault. Doctors, nurses, pharmacists, and the people that are in healthcare. So we need to own up to this, right? And the reason for this medical error, I'm going to talk about a little bit today. So this was a big thing for me. So I'm about midway into my career. And I started medical school in 1997. So I can't believe that it's been over 20 years since medical school, but our official clock starts after residency. So since residency, it's only been about 13 or 14 years. But this was a big deal for me because when I came out of residency, I just assumed that if you make an error taking care of a patient, that was really, really bad, and that patients are going to die. And I was wrong, because not all errors lead to harm. That makes perfect sense, right? Because I didn't get any training. So I'm out of my residency training, right? And I didn't understand that errors, yes, they're bad, but they don't necessarily mean that someone's going to die, right? So in my head, it was such an intense thing that was ingrained into me throughout my training, throughout my school, that any error is going to cause death. So once I realized this Swiss cheese model of care also made me feel a little bit better about myself because, and this is true, it's true in the hospital, it's true in life, that most systems, whether we're driving a car or whether we're getting our gallbladder taken out or whether we're getting a medication, a Tylenol at the bedside, there's lots of things in place that prevent errors. So if I wrote the Tylenol for this gentleman and the nurse accidentally gives it to this gentleman, we have lots of things in place to prevent that from happening. And that's what each of the slices of cheese is. So when an error actually becomes harm, it's because everything is aligned. Everything is all, the perfect storm is happening. And for most things, that's the way it is in healthcare. However, that creates complexity, right? So this complexity is a big part of why we make so many errors. So this idea of high reliability is not necessarily new, but it's new for people in healthcare. We are only now, in the last 15, 20 years or so, understanding what this term means. High reliability organizations are organizations where the risk for errors are managed before they can become harm, where small errors can become disasters like death. Okay, so as I mentioned earlier, airline industry, any mass transit, chemical plants, defense, Department of Defense, and military type things. These are all high reliability. We try to be high reliability organizations, and it takes a lot. It takes a whole lot to be a high reliability organization. And I can tell you my first story. So when I was 4 years old, I remember very distinctly. My mother and father were laying in bed. It was probably 8 or 9 p.m. and it was around time to go to sleep. And I remember I was laying in my mom's lap. I was just like messing around, playing with her. And she said, "You are going to be a doctor." And I said, "Oh, that sounds pretty good. Okay, I'll be a doctor." And luckily, she was right. I really loved medicine. I really loved science. And throughout my training, from a very early age, I knew that I was going to be a doctor. So Pakistani heritage. I'm a first generation. I'm what's called an ABCD. Anybody know what an ABCD is? ABC, so some people in the back know. American born confused desi. That's what I am. I'm not so confused though. So in my high school years, and again, this was ingrained into my head, right? This is going to be a theme of my conversation with you guys today. What was ingrained into my head is that if you don't do science, you're stupid, or you're bad, or you're wrong, or you're not good enough, right? And so growing up, this is kind of what I was, not overtly, but just subtly, from my family members, friends, just that my community, they kind of, and growing up in the 60s, 70s, and 80s, right? This was the mentality that I grew up with. So when I had my sociology course, right, I just discounted it out. This sociology doesn't matter. Who cares? Like, this is not going to help me at all, right? What does sociology have to do with anything? I remember very clearly when I was in high school. I mean, I still got a good grade in it. I think I got, an A- or something, because I did the work that needed to be done, but I didn't care about it. And I remember that very distinctly, and you'll understand why in a few minutes. And so I go through my college years, same thing, my economics course, all my non-science courses, I really discounted. Although I did love my computer science courses. I did very well with computer science, and I loved computer science. So fast forward now to today, right? So I became, somebody one day when I had my first job out of residency handed me a $200,000 check and said, please start a medical simulation center. So this medical simulation center was a place for us to simulate what happens at the bedside, or in the ED, or in the OR, or in the cath lab, right? And so basically I was so happy. I had this $200,000 check, I bought all this fancy equipment, an $80,000 mannequin and all these things. And now the first day comes, we get some residents and some nurses and some other students, and we start training, and I flip the button on the mannequin, and the mannequin starts talking, pre-programmed, to these residents, and they're all enamored, oh, this is pretty cool. And the student doesn't respond with what with what I expected them to respond with, and now the mannequin is not communicating with this student. So basically, I had to step in myself and become the mannequin. I had no idea that I had to learn how to act to do medical simulation. I thought it was technology, and I thought it was education, but it was not at all medical simulation. And to take it one step further, my organization was very nice. They sent me for training. I went to Harvard. Harvard had a fantastic simulation course. And I'm sitting in the classroom with 20 other people like me, doctors and nurses and all kinds of clinical people. And in walk two Harvard professors, one woman and one man, mid 40s, looking like really smart, intelligent people. And they write their names on the wall. And one is a PhD in sociology, and the other one is a PhD in sociology. No clinical experience at all, zero. And doctors and nurses in the audience as students, right? So that was a long-winded way of telling you that the way we were trained as physicians, nurses, pharmacists, all of us, needs some revision. It's not the way it used to be. And fortunately now, today's students are doing way better than we are. So my students that I have today, they have medical simulation, they have, their entire program is set up so that they can deal with and take care of patients using the information that's literally at their fingertips, where we were trained to memorize. Memorize this and memorize that and understand, how this interaction is with that interaction. But, there was a limited amount of information, and it was within reach to memorize for most doctors. But obviously that's now changed. So information is now a commodity, not a resource. So looking at the complexity of healthcare, it's very, very hard to make any sense, of all the various things. So what I've done is I've brought it down to my favorites. These are the things that, in my opinion, cause the complexity that we have in healthcare. Can I just ask, is this time is not jiving, so please help me with the time, somebody. Just give me a 20-minute and a 10-minute warning, okay? So starting with, and this is where my integrative kind of background comes in. So I didn't tell you a lot about my actual work, my primary role as an informaticist. So that's what Chief Medical Information Officers, typically we call ourselves informaticists. So what does that mean? So we specialize in two things. So we're supposed to be leaders. We're supposed to lead other people into, delivering better care, or kind of quote unquote doing the right thing. That's the number one most important thing that anybody that has a chief in their name in a hospital needs to do. And then the second piece is we are workflow experts. So we need to understand how that Tylenol came from the factory to the bedside, and we need to understand that it took over 50 sets of hands for that to happen. And when it takes 50 sets of hands to get a single Tylenol pill from the factory into somebody's GI tract, that's a complex system, right? And about 20 plus of those hands are in the hospital itself. So from the loading dock to the bedside, to the patient's mouth really, is over 20 hands. And so these two skills are kind of what a good CMIO has. Now notice I didn't say technology, right? So most people would think that you have to be a technologist to be a CMIO. That's not true. I think, and I'm a big techie. I'm a super technologist as far as CMIOs go. And I think that's a detriment. I think for people that are in my role, having a strong technology background is bad. Because what I tend to do, and I try to do it less now, I try consciously to do it less, is I reach for the technology solution when the answer is not a technology solution, it's a workflow solution, right? So I have to kind of try to not reach for that. I have to try to do the right thing, for the patient. So anyway, so these two skills are what I use on a daily basis. And again, my training was really absent with either of these. I mean, leadership, yes, you get some, you get leadership by, my training in medical school and residency, you get leadership by example. Nobody sat me down and said, these are the principles of leadership. I actually got an MBA, and I was very fortunate to be able to do that, and where the focus was leadership, so I was very, very lucky to get that kind of training, but most doctors don't get it. And the good news, though, is that most doctors especially are pretty smart, so that leadership by example, is not that bad. They learn a lot of really good leadership skills just by watching good leaders, lead. So the training process is a big part of the predicament that we're in. And by the way, just to remind you, we spent about $3 trillion a year over the past, I would say, 5 to 10 years on average. We were supposed to, Obamacare and all the changes that have gone into place over the past 10 years, we're supposed to reduce that. We spent $3.5 trillion last year. So the costs are going up. However, I have to say that I think that things are getting better. I think things are getting better, and I'll explain more of that in a few more slides. So for me, the food supply, this is an interesting one. So this one, I have to just be another personal story of mine. You can see I'm not necessarily obese. I definitely have a belly here. I'm 43 years old, so my belly is starting to come out a little bit. But when I was 35, I was like a stick figure. I was very thin, and I played basketball. My children were pretty small then, and I got to play with them. I had no problems, and I had fatty liver disease. So how does that happen? How does a thin person who looks like a stick figure have fatty liver disease, right? It's because I ate crap. I didn't eat good food. I didn't know. I used to drink 4, 5, 6 cans of soda a day. I would eat fast food all the time. Like, if I had to go from one hospital to another, I would time it perfectly so that I could stop at, Burger King or Taco Bell or any of these places on the way. And to me, I'm eating great food. I'm eating, good food. Because I was an idiot, right? I mean, most people at that time knew better. But then I thought, when I got this diagnosis, and how did I get the diagnosis? Not because I felt bad or anything, it was because I tweaked my back, and somebody asked me to get an MRI. I got the MRI, and I'm looking at my back, and all of a sudden I look over, and I see my liver, and I asked the radiologist, I'm like, what is this junk in my liver? He's like, oh, that's fat. And then he looked at it and said, oh, you have NASH, non-alcoholic steatohepatitis. That's a fancy name for fatty liver. And you know what I said? 35 years old. You know what I said? I said, no, that's artifact. I'm not a radiologist, right? I'm not a radiologist, but I'm telling the radiologist how to do his job because I really believe that it was artifact. It's because it was in my head. Who knows better than me? I'm a board-certified internal medicine doctor. I'm the one that these NASH patients come to. I'm the one that writes the scripts. I'm the one that takes care of these patients, not the radiologist. He doesn't know anything, right? All right. So long story short, it took me 2 years. So at age 37 is when I realized that, you know what? I did have NASH, right? And maybe I should do something about it because NASH can kill you. It can be a fatal disease, right? If you don't take care of it. So let's change gears then and go into some challenges. So this was showing you a little bit of complexity. I tried to highlight the sociology of the complexity. I mean, there's a lot more we can talk about. Each of these slides is literally a day's conference. I mean, there's so much information. My job today is to just kind of let you touch on some of it, because a lot of the answers here, I believe, is in machine learning and in AI. So here I am. I'm a cowboy, right? I'm a cowboy because nobody knows better than me. The radiologist doesn't know better than me. You know what else? And I'll tell you that right after my residency again, and usually when you complete your residency is when you're supposed to be the smartest, right? You just finished your training, you got all the latest information, and yes, you don't have a whole lot of experience, but you know the knowledge. You know, you have all the literature kind of in your back pocket, right? It's fresh in your mind, right? So I had decided that I don't need to wash my hands. On my board, my internal medicine board exam, one of the questions, I had all these, it was a very hard exam. One of the questions was, which of the following is the best way to reduce hospital-acquired infections? And the answer was, wash your hands. I got the question right, but I didn't wash my hands. And I didn't wash my hands on purpose. If I walked into a room, I would always wash my hands, but if I forgot, I would look at the patient and say, you know what, I'm not gonna touch the patient. I'm okay, I don't need to wash my hands. I'm a doctor. The nurses have to wash their hands. The techs have to wash, everybody else has to wash their hands with me. You know? Sometimes I would put on a pair of gloves. And it wasn't until my chief medical officer at the time, he stood in front of a group just like this and on a big stage, and he put it on the screen. We had done some hand washing initiatives, and we reduced hospital-acquired infection by 60%, just by hand washing. And when I saw that data is when it clicked in my head that, you know, maybe I should wash my hands, you know. But the cowboy in me wouldn't let me. So as a punishment to myself, I wear a pin now on my white coat that says, it's okay to ask me if I've washed my hands. So that's my punishment. That reminds me, you know, people laugh when they see the pin, but it's serious. And patients sometimes will ask, did you wash your hands? And most of the time, I have. But if I haven't, I thank them and I go wash my hands. Cost is another huge challenge. So this is not a video, but there is a video of this man. He's a war veteran. He unfortunately lost both his arms. And they're outfitting him with what you can see here. It looks like these two robotic arms. They're plugged into his, they're not plugged in, but they're attached to his brain superficially, just like with some glue. And he can control these arms with brain waves. It is amazing technology, amazing. And you can see the video, I'm not gonna play it here, but you know, when you leave here, take a minute and watch this, it's fantastic. This is how we in the US deal with you know, this problem, bilateral amputation, right? And this is a good solution. You know, I don't know how much this costs, but it's not cheap, I can guarantee you, okay? Contrast that with this video. So this is a man in India. There's a video of this as well. Actually, if any of you are on my LinkedIn, I have these videos on my LinkedIn from a couple weeks ago. He's also bilateral. I don't know if he's an amputee or if he didn't have his arms from birth, if it's congenital, but he is a tailor. He works as a tailor. That is his profession. He makes money as a tailor. And if you see this video, it is absolutely amazing what he can do with his feet. He brushes his teeth, he eats his breakfast, he can sew you a beautiful shirt or a pair of pants. And again, I'm not saying that one is better than the other. I'm just saying that here are the same problem in two different cultures, in two different societies, and they're being dealt with differently. Obviously, you know, in India where he lives, they probably don't have technology the way I showed earlier, but they may do with what they have, and you know, he's thriving. He's doing very, very well. And then at the end of the day, we have all this data, and I spend most of my time every day, you know, talking to my colleagues and my friends and about data, you know, because everybody knows me as the data guy, you know, because they know that when I come to them with a problem, right? So what do I do all day, really? What I do all day is I fight with people, right? I mean, I'm on the phone fighting with somebody or in person fighting with somebody. No, I'm really playing. I don't really fight with people. People are very, very nice. But just like me, without the data, nobody wants to change. So my title, Chief Medical Information Officer, it really shouldn't be that. It should be Chief Change Officer, because that's kind of what I'm supposed to do. That's my job. I'm supposed to make people see things in a different way for the better, hopefully, right? And fortunately, most of the time I'm right. I'm not always right, but I'm right because I have the data. So the data empowers me. And like I said, we have so much data, and we collect data. Just 2 days ago, we were in a committee meeting, and and this meeting had 30 people in it, and 6 or 7 of these people are doctors, very highly paid, very competent, terrific, clinicians, nurses, pharmacists. I mean, that one meeting probably cost 1 hour of all those people's time added up is probably 10 grand. It was a lot of brain power in that room and a lot of cost, right? And here we are collecting this data, and I asked a simple question, like, what are you going to do with this data? And just like now, the room was completely silent. So then we talked about it, and we said, well, maybe we shouldn't collect this data anymore. They were spending 15, 20 hours a month, collecting this data. And we do this all the time. We collect so much data, and it's comical sometimes, and most of this data is manual, right? Again, this is where you guys come in, because a lot of this data, 90% of our data is unstructured. So only 10% of our data is actually structured. So they're taking unstructured data and trying to make it structured manually so that we can submit it to CMS, or that we can submit it to the Department of Health, or that we can get, to the payer so that we can get reimbursed, we can get an incentive. These are the problems, that we're facing. This is a huge problem, the data problem. And as I said, we will not change. I will not change because I'm a cowboy, right? I will not change unless you show me the data. And the data's got to be something that I can understand. Because I'm smart, right? But until you give me something that I don't have to process, that I don't have to spend a lot of time trying to understand, I'm not going to change. Okay, so how am I doing with time? Anybody? How much time? Bad? 5 minutes left? Okay. Let me just wrap this up then. So in terms of solutions, you guys have the solutions. I think I'm supposed to go till 3, right? Or 3:40. No? How much time? 2 minutes. Okay, thank you. Okay, so you guys have the answers. We need you to help us develop solutions that will process this data and give it back to us so that we can get to predictions. We need you to tell us at the bedside, and just this morning before I came here, I had a conversation with one of our doctors who came in and said, if we can have this dashboard that shows us the DRG, the working DRG for every patient, and the working DRG means the diagnosis, like what are we treating here, pneumonia, heart attack, stroke, and it can tell us what the expected length of stay should be. That's going to be awesome, because then we can know, if we're off or on, or what we need to do for this patient on a daily basis. That is awesome. That was awesome. And this is one of the first times that that's happened, that from somebody at the front line is coming to me and asking for this, right? It's beautiful. This is like my dream, right? So now, how are we going to make this happen? It's a lot of work. It's a lot of work for us to do that. And again, you guys have the answer. We don't have the answers within the healthcare system itself today. The last thing I'll just say is, incentivizing health, you guys know we have Fitbit, we have all this technology, but really de-incentivizing poor health. So my lack of knowledge about food as a physician, as an internist, right, that shouldn't happen. Our physicians need to know how to eat and how to deliver nutrition. We need more than 4 hours in 4 years of nutrition training, right? And we need to understand better how these foods actually lead to most of the chronic diseases. Those 19 chronic diseases I showed earlier, with the exception of with the exception of accidents, all 18 of those other diseases can be cured with diet and lifestyle modification, if you catch it early enough. So in summary, we have a very, very complex environment maybe more than any other industry. I believe that it's more than any other industry. Our challenges are very, very daunting, but the good news is we are smart, and we need, these solutions, these machine learning and technology solutions to help us process this data so that we can get to the answers. So I apologize for going over. I can't believe that was 40 minutes. If there's questions, please come and see me afterwards.